please.
Okay, thank you again. So I'm going to present to you the personalized risk prediction modeling and for liver cancer and also for colorectal cancer. And in this presentation, I will incorporate not only the biomarkers, but also the age, gender, smoking status, and the BMI. So for the risk prediction, so what is the risk prediction? And actually it's fortune telling. So, but it's an educated fortune telling. And the trick of the risk prediction or the fortune teller is that the more data you have and the more accurate the prediction will be. So cancer, due to the complex tumor genesis and the overcoming cancer, the central issue is the heterogeneity. The cancer heterogeneity can be manifested by the several aspects, and from the development to the treatment to the clinical outcome. As you have seen, so there is a wide variation in terms of genetic predisposition to cancer development. And some individuals might develop cancer very early, and some might develop cancer, not develop cancer, even they have been drinking and smoking for their lifetime. And also there is a variation in terms of reaction to environmental exposure. And for example, in the case of lung cancer, the major risk factor for lung cancer is smoking. So 80% of the lung cancers are from ever smokers. And however, only 12% of the smokers will develop cancer. So that is because of the variations, because of the variations in the response to the environmental exposure. And there is also a variation in terms of response to treatment. For example, for a cancer patient, even the diagnosis as the same cancer site, same stage, and treated with the same drug, and the response could be different. And some patients might respond very well, and some patients might not respond, and some patients might even experience toxicity. And also, the treatment effects on the clinical outcome has a wide variation, and some will have the adverse long-term toxicity, and some might have relapse and also develop second primary cancers. So the cause of heterogeneity is because of the genes we inherit from each of our parents, so they are different. And also, the heterogeneity is also because of the mutations in the tumor tissue. There is a wide variation of the cancer somatic mutations, and also the variation in the microbiome cell genes, and also the environment we have exposed. The environment including not only the external environment, but also the microenvironment inside the human body. So from the patient's perspective, because of all these wide variations, also the heterogeneity of the tumor, so the patients want to know, what is my risk of cancer, and what screening options are the best options for me? And if I have a high risk for cancer, what kind of prevention interventions could help me to reduce my risk? And also for patients who develop the cancer, and they might want to know what are the treatment options, and also if a patient diagnosed with cancer, but the cancer might be predicted not to be so aggressive, but the treatment could bring in substantial toxicity. So like the patients diagnosed with prostate cancer, so they might want to know whether I should receive this treatment. And so the prediction model can help the patients and the clinicians to make the clinical decision. So the prediction models can apply across the cancer continuum. And from the healthy individuals, that is before the cancer diagnosis, and all the way to the survivorship, that is after the cancer diagnosis. And then the risk predictors or risk prediction models can help to predict the cancer development and can also predict the cause of the disease, and also can identify the targets for prevention and the targets for treatment, and therefore to enable the personalized prevention and intervention. And the results from the prediction model can be utilized to help the risk management across the cancer continuum, and this will include the behavior changes and the prevention intervention, evidence-based screening. So some individuals might be needed to screen at an early age, younger age. Some people might need to be screened more frequently. And also, this model can be utilized for risk-stratified clinical trial, personalized therapy, and risk-stratified follow-up for the quality of life. So in the general population, there is a wider range of cancer risk. And here is an example of breast cancer. And so the risk for breast cancer, and here you can see the majority of patients have a low risk. Their lifetime risk for breast cancer development is below 15%. And then here has the moderate risk, the risk is between 15 to 25, and then there is a small subset of the women can develop a breast cancer, and this is a high-risk group. And then individuals, they can, based on their risk, can take the different measures for prevention, and some might choose change their lifestyle to a more healthy lifestyle, including exercise or the healthy diet. And some patients, some individuals might take a preventive measures like the surgery. And this is really dependent on what's the risk for this woman, and also what is their personal belief. And this risk can be predicted and by their genetic background, family history, and also the environmental exposures. So the current status of the cancer prediction models is that most of the cancer prediction models have moderate prediction power. Therefore, there is limited utility to be translated into the clinical practice. And so the breast cancer risk model has been the most widely studied risk prediction model, and also has been utilized in the clinic. However, the prediction is very moderate. It's only 60% to 70% of the prediction. And also many of these models has not been validated. And therefore, the critical need for all these cancer risk prediction models is we need to identify and incorporate the novel biomarkers and the clinical phenotype to increase the prediction power, and therefore they can be utilized in the clinic. And now there is a good opportunity, and because of the advancement of the biotechnology and also the advancement in terms of bioinformatics, and so now with the biotechnology development, and now we can identify promising new genomic and omic markers, and also the prediction methodology are more mature, and also it has already showed evidence for effective screening in terms of reduced risk. And this is the two other examples to show that the incorporating the genetic markers can help to predict the cancer risk. And this study is again on the breast cancer risk. And what they did is they utilized about 100 genetic loci, and that are identified from the GWAS, Genome-Wide Scan Association studies, and then they grouped individuals with high risk, intermediate risk, and low risk, and then they analyzed with their family history. And here you can see, if the person has the high risk genetic background, and plus they have a family history, they, according to their study, and the woman needed to start to do the screening at the age 31 years old. However, for the individuals, they have the low risk genetic background and without family history, and they might not need to have a screening for breast cancer over their lifetime. So this is really to show so the risk prediction models can have the clinical applications, and also the genetic markers can improve the prediction. And this is a study from US, and this is from UK, this is from US, and this one is on the colon cancer. And again, it is found so that individuals with high risk and with family history, and they need to be screened early, and then individuals with low risk and also the family history, and they can be started the screening age at a later time. So we have taken an integrative approach to build up this risk prediction model, and with the hope to reduce the cancer burden. So what we have done is first to build up a study population, build up the cohort, and then look at their modifiable risk factors and also the genetic predictors for the integrated risk assessment. And then we incorporate all these information to perform the multi-layer analysis to build up the personalized risk prediction model. And then with the collaboration with the industry and the clinical trials, hopefully we can implement this risk prediction model in the clinic or in the community, and for personalized risk management, for prevention and for the therapy. And then this risk prediction model can help to influence the public attitude, and also hopefully can work with the policymakers to change the policy in terms of prevention and to benefit not only the cancer patients, but also patients at high risk for cancer and also the general population. So this is the summary of the approach: cohort building, and then modifiable risk factors identification, biomarkers, signature, and then risk prediction model. So next, I will share with you two risk prediction models we have built for GI cancers. And one is a liver cancer prediction model, and another one is a colorectal cancer risk prediction model. And here there are the rationale and why we need to build up a liver cancer risk prediction model. As you know, the carriers of the HPV and HCV are at increased risk for liver cancer. And however, most of the Americans with the HPV or HCV infection are not aware of their risk. And also, the liver cancers, 30 to 40% of them occur among non-carriers of HPV or HCV in the Western population. And at the time when we started to build up this risk prediction model, and at that time, the risk prediction model, the only existing prediction model, are limited to individuals who are carriers of HPV or HCV. So what we wanted to do is to create a model, simple, efficient, and can be widely available to identify and quantify the liver cancer risk in a routine clinics. And we use the cohort that was developed from Taiwan. This is a health screening cohort, and this cohort, and it has over 600,000 individuals, and it has been followed up for over 11 years. And this cohort has some really unique advantages. Not only it has epidemiology data. The epidemiology data is a short questionnaire, but they covers from demographic to family history to from diet and to the exposures, and also cover the physical activity and the sleep disorders. So it's a really good questionnaire. And also, in addition to all these epidemiology data, they also have the health screening information. So they have the blood test, lung function, kidney function, and this is a very unique cohort. And also, this cohort has identify many cancers. And so we have utilized this cohort to develop many personalized risk prediction models, and so including the liver cancer model. And using this cohort, we have identified over 420,000 eligible individuals for this analysis. And the average follow-up year is 8.5 years. And then we identify over 1,600 incident cases of liver cancer. Then what we did is divided the cohort into two sub-cohorts. One is without the HCV test, and one is with HCV test, because the HCV test is more expensive, and so some of the individuals do not have the HCV test. And then in each cohort, we use the training set and the validation set to develop the model. And here is a model for the sub-cohort without the HCV test. We developed the model, actually, we developed 4 models, and one is based on the questionnaire only, another based on the blood biomarkers only, and then another model is combined the questionnaire and the blood test, and then the last model is incorporate the questionnaire information, the blood biomarker, and also the HBV status. And what we found is that even with the healthy history, the prediction is quite strong. It's 80% accuracy. And the most interesting finding we found is the 2 transplantases. The ALT and AST are the most strong predictors. The predictive power is over 90%. And the 4 model is about 92% prediction. Then in the sub-cohort with the HCV test, and again, we found that the blood test, the 2 biomarkers, is the most strong predictor. And then when we incorporate all the information, the 4 model is over 93% prediction. And then we use this risk prediction model to calculate and to predict the person's chance of developing cancer in the next 1 year, next 2 years, next 5 years, and next 10 years. And here is the data for the next 5 years and for the 10 years. And here are the 2 hypothetical examples. And in these 2 examples, and you see the 2 individuals, their age, gender, biomarkers, and also the infections for the HBV, HCV, and AFP, and they're the same. The only difference is the modifiable risk factors. And for this individual, and this person is a smoker, a drinker, and also does not like exercise and diabetes, and also has diabetes. And then these individuals and is a non-smoker, non-drinker, and exercise and diabetes are managed well. And here you can see these 2 individuals, you see their risk is significantly reduced. Therefore, this risk prediction model could be utilized to promote individuals to select a healthy lifestyle. And this might be needed push for individuals to choose a healthy lifestyle. Then because this risk prediction model is built up from a prospective cohort and with a large, like with over 420 subjects and with a long follow-up. So we thought this prediction model could hopefully to be applied into the clinic. And therefore, in collaboration with investigators from Methodist, and we obtained a grant to translate this risk prediction model to a point-of-care V-diagnostic chip. So basically in this analysis, in this chip, you use 1 drop of blood samples, and then you can measure over 10 proteins, 10 biomarkers, and then the results can be shown as a bar graph, and then the data can be transmitted through the cellular phone and to the physicians. And therefore the individuals, they can monitor their risk at home. and then the data can be transmitted to the clinic. This could really help to monitor the liver cancer risk and to reduce the liver cancer risk. So another model I want to present is a risk prediction model for colorectal cancer. And again, we use the MJ cohort, which is developed in Taiwan. So the rationale for developing the personalized risk prediction model for colorectal cancer is that in US, the current guidelines for colorectal cancer screening are limited to individuals above age 50. And so there are no guidelines for screening for individuals has the average risk or below age 50, younger than 50. However, the problem is that this younger group, the colorectal cancer is increasing. And also, 25% of the colorectal cancers occurred in this age group. Therefore, our purpose is, again, to develop a simple, efficiently, and the models to predict the colorectal cancer risk. And this is the current status for colorectal cancer risk model, and this is from the literature, and you can see the prediction power is only 61% to 71%. So this prediction power is impossible to be applied into the clinic. And we analyzed the Taiwan cohort, the MJ cohort, and we performed the univariate analysis and the multivariate analysis, and here are some of the results. And when we look at the questionnaire data, and for the non-specified the questions in the questionnaire, we found that older age, male, smoking, drinking, and physical, inactive, and also the inactive and low fruits and vegetables, and also high BMI and family history are the significant predictors for colorectal cancer, but these two are not significant. Then in the questions, for the specific questions relevant to colorectal cancer, and we found the black color store, the history of black colored store, and bone hepatic change also are the significant risk factors for colorectal cancer risk. And then when we look at the blood testing and also the medical history, we find that the diabetes, hypertension, anemia, and CGN and CIP are the significant predictors for colorectal cancer risk. And one interesting finding is about the IFOBT biomarker. And the current recommendation for the IFOBT is using the 100 unit and per meal as a cutoff point. So basically, the individuals, if the biomarker is above 100, they classified as positive. And if it's below, it's classified as negative. But from our finding, we found that we need to classify the individuals based on their age and also their level. So what we found is that the risk for colorectal cancer is increased as the biomarker level is increased. And also this risk is also increased as the age increasing. So therefore, we really need to consider both. So here is a figure to show the IFOBT level and the colorectal cancer incidence, and this is by the different age group. And you can see for individuals older than 60 years old, and the risk for individuals with a biomarker from 100 to 199, the risk is similar to individuals like who are younger than 50, but the biomarker is over 1,000. So this is really to show that we needed to use a different cutoff point for the colorectal cancer screening and for using the IFOBT test. And this we found a similar situation for the mortality analysis. And then we also said, okay, let's see whether we can use the IFOPT to select the candidates for colonoscopy. And what we found is that as the level of this biomarker increased and the number needed to be screened, to be scoped to identify one colon cancer, you see the number is significantly reduced. And also it is consistent for the different age group. Then we also look at the lead time survival between the date for the this biomarker screening and the data of the cancer development and the death from this cancer. And here you can see as this biomarker increased, the leading time for cancer incidence is shortening. And also the leading time for the mortality is also shortening as the biomarker level increased. Then we developed the models based on their different profiles, like based on the questionnaire and based on the lab test and also based on the IFOPT biomarker and also the 4 model. And you can see here the model 3 and 4 incorporated with this biomarker. And so in our risk prediction models, we found that the models incorporated with this biomarker and has a significantly improved prediction power. It's over 88%. So this is really to indicate that with additional biomarkers, we could potentially to push this personalized risk prediction model for colorectal cancer into the clinic. And this is a model for mortality. And you see, for mortality, the prediction even reached to almost 91%. And this is just to show you how we can utilize this model to predict the absolute risk in 5 years and in 10 years. And these are some examples of the individuals. And so the first example are the individuals with no risk or low risk, and the absolute risk for 5 years, for 10 years is below 1%. And however, when the person has some, has the family history and also with not exercise and also other risk factors, and then the risk is increased from 1.4% to 3.4% for 5 year and 10 years risk. And then when we add the black store, the color, the history of black store, and also the history of bone habit change, and the risk is even increased from 2.7 to 6.4. And then you see when we add the medical history and also the biomarkers, the risk is even increased. And for this one, when we really have a high FIT biomarkers, so this risk is huge. And so this one is to show when we use the number of risk factors, you can see their risk is proportional increased. And so that is the prediction model for personal risk prediction. And hopefully with the addition of novel markers, we try to push it into the clinic. And next, I will just use a couple of minutes to mention about not only we use the health screening cohort to build risk prediction models for cancer development. And as I mentioned earlier, we also create a pre-cancer lesion cohort. And we hope use this cohort and we can develop the models to predict the progression for individuals with pre-cancer to cancer. And another cohort we are building at MD is an MD cancer patients and survivors cohort. And this was started about 5 years ago, or 6 years ago. So in this cohort, what we do is we combining the patient history database. It's when patients come to MD Anderson, we give them a questionnaire to collect the core risk factor information. And then we also collect the blood specimen blood specimen. So basically, every patient, they came to MD Anderson, when they started to do the financial clearance, we asked them to sign a consent. Said, okay, if you have the residual blood samples from your routine clinical testing, can we keep the blood samples? And also, all the data, the clinical data, and also the epidemiology data, can we also utilize for the research? And then we also collect the information from our electronic health records. And then this cohort, it's become a powerful resource to predict all the range of the clinical endpoints from the recurrence, toxicity, therapeutic response to survival. And this is just one example to show we have utilized this cohort to predict the recurrence for the trick-negative female breast cancer. And now this cohort can also be utilized to build up a risk prediction model for colorectal cancer clinical outcome. And now we also, based on our MD Anderson cancer patient cohort, we also built up a long-term survivorship cohort. So basically, we recruit the patients who have survived more than 3 years and then build up a cohort. Then this cohort can be utilized to look at the long-term adverse events for the survivors, and this cohort can also be utilized for the colorectal cancer survivorship analysis. Finally, so our goal is when the patients come to MD Anderson, we want to give them a questionnaire, and we want to collect their blood sample, and then this information can be utilized to develop web-based risk prediction tools and to assess their cancer risk and also identify their risk factors. And then this tool can also help to identify their risk behaviors. And for example, if the person are heavy smokers, or the person doesn't do exercise, or have a high BMI, and then in these individuals can be recommended to our risk reduction program. And then during their clinical visit, we can incorporate the molecular informations and with the epidemiology and the clinical data, and then this multi-dimensional data analysis could help the patients and the clinicians to make the clinical decision and to help to improve the clinical outcome or the survivorship. So now I want to thank all my collaborators, and again, thank you for listening.
Thank you, Professor Wu. Now we open for the questions. So let me, okay. Yes.
Again, hello. Again, this, I think this is what we have done some part of it in our unit. I want to share some of our experience. Just to let you know that colon cancer is top 3 leading cancer in Thailand. We have screening program for breast, for cervical cancer, but not for colon cancer as of yet. But we are planning. That's why we have you here. So far, I think the problem for us that this is the first screening if you do FIT, but you still have to follow by endoscopy or colonoscopy that's need to be performed by physician. Unfortunately, we are so limited in terms of manpower. Can you believe that we have both sides surgical, and also gastroenterologist, probably less than 2,000 to perform, those eligible for, the endoscopy. So what we have done, that's the same thing. Recently, we published one in GIE and gastroenterology. we use the risk score, quite similar to what you have said. Family history, smoking, the age, things like that, plus the FIT. So we brought those with, double positive, high risk score, and FIT to be screened as a first group. If we have time, we take either one positive, FIT positive, and also the family history positive. For the overall, we also done the quantitative FIT, and we have found that we cut that from 25, 50, 100, 150 to 100 nanogram of FIT, and we have found that 150 nanogram may be the best for us because the workload, 4-time reduction of workload comparing to using the 100 nanogram as many people recommended. But with this, we did not encounter any false negative rate. So this is the plan for our country, and we're gonna check it again for the bigger population. With this, we capture from 1,500 asymptomatic case from 6 centers in Thailand, including 3 in Bangkok, another 3 from other city outside Bangkok. So this is just what we have done so far. Sure.
Very nice, very impressive.
Rangsan, that's really fascinating. I just wanted to find out, these are the cancers that you found when you have the cutoff, or is it advanced lesions that you found?
Yeah, good point. I didn't go in detail. Yes, we have missed some, simple adenoma, but we did not miss advanced adenoma or cancer from this cutoff. Yeah, of course. Yes, if we use 25 nanogram, we have seen a lot, even false positive. But this is quite, the appropriate number for us at the moment.
Yeah, actually it's very interesting. And also from our analysis, and I have not showed the data today, so what we found, if the person has been found the FIT, the value is very low, and if for 3 times, and then their cancer risk is really, really low. So the FIT analysis could be very useful for the colon cancer screening.
Only problem for us is that 150 is not commercially available. They usually have either 75 or 100, or even 200. So you have to ask the company to make one. Thank you.
So in your plan, you plan to do something like the molecular subtype, using the microfluidic.
Yes.
Is that based on the progression model in the adenoma in terms of the markers that you want to do?
And actually for our MG cohort, we does not have the tumor tissue data. So we are going to, basically we identify the driver genes so we can see whether we can develop the blood-based testing.
Mm-hmm.
Yeah. For example, look at the mutations in the circulating, in the circulating mutations.
Mm-hmm. Okay. All right. We're a little bit behind the schedule. I think if no further questions, I would end the session. And Dr. Pascal.
Okay, ladies and gentlemen, we have a token of appreciation. May I invite Professor Suthep Konchanwit, Deputy Director of Medical and Research, to present the token of appreciation to our speakers and our moderator. Please on the stage, please. Thank you. May I inform you that we will have a little break for 10 minutes and we will start the next session on time. May I inform you the restrooms are located on the upper floor and where we are and on your right as you exit the door, and the coffee break will be served in the room across of this room. Thank you.